uh, that I've had a lot of interest in since residency at University of Kentucky. They do have a specialty adult ADHD clinic in their outpatient office, and all the residents had an opportunity to rotate through it. And so I found that a really interesting experience, and have kind of continued that interest into my practice here at U of L. So we'll go ahead and get started here. So again, I don't have any disclosures to share, so nothing of note there. And identified a few learning objectives for us to cover today. We'll cover more than this material, but I think these are the important things. Let me see if I can hide the Zoom stuff here. Okay. So first, I'd like to present an argument for adult ADHD, potentially as a separate diagnostic entity from childhood ADHD. And then I'd like to outline the diagnostic process for ADHD in adults, and then talk about selecting appropriate treatments for adult ADHD as well. Before we actually jump into the meat of the talk here, I'm also involved right now in the health professions education graduate certificate program. And so I'm learning all about the science behind learning and teaching. And one of the principles that I've learned is that one way to improve learning is to practice some prediction about what we're going to learn. And so with that in mind, I have a couple of questions that I've put here. First, what's the estimated prevalence of ADHD in adult patients? And then what's the most effective strategy for diagnosing ADHD in adult patients? And what medication is best for adult ADHD when considering both efficacy and tolerability? So I'd like you all just to take a moment here, think about these questions, think about how you would answer them, and we'll talk about this as we go along. Okay, so I thought a good way to set the stage here would be to cover a brief history of ADHD as a psychiatric diagnosis. And to do this, we have to look back pretty far, all the way back to the late 1700s. There was a Scottish physician named Sir Alexander Crichton. He did have an interest in mental illness, and in 1798, he published a book, the title of which I have here because I wouldn't remember it without some notes. It was called An Inquiry into the Nature and Origin of Mental Derangement, Comprehending a Concise System of the Physiology and Pathology of the Human Mind, and a History of the Passions and Their Effects. I found it kind of funny that he used the word concise in that title. All that said, it's the second chapter of book 2 of this volume that is particularly interesting in terms of ADHD. This chapter was titled On Attention and Its Diseases. And so in this chapter, he described patients who had what he described as an incapacity of attending with a necessary degree of constancy to any one object. He also said these individuals, they're incessantly withdrawn from one impression to another. So in modern terms, we might say they have trouble paying attention to things, and they're easily distracted. He said of these patients that the incapacity renders them incapable of attending with constancy to any one object of education, that the symptoms become evident at a very, very early period of life, and that they generally diminish with age. So you might recognize that a lot of what's described there is characteristic of how we think about ADHD even today, right? That symptoms often start at a very young age, that they affect individuals in their schooling and education, and that generally symptoms tend to improve with age. So even as far back as 1798, there were patients who were demonstrating symptoms consistent with what we think about as ADHD today. And then moving forward a little bit into the 1840s, specifically 1844, there was a German psychiatrist, Heinrich Hoffmann. He wrote a children's book, and which has a German title that I'm going to butcher here. Struwwelpeter, I think, is what it eventually became to be known as. But I also wanted to share the original title of this one. It was Cheerful Stories and Funny Pictures with 15 Colored Plates for Children from 3 to 6 Years. So, and again, another nice, concise title there. This book actually has gone on to have like hundreds of editions, I believe, and has sold a lot of copies. But anyhow, in the first volume, the first edition that he wrote way back in the 1840s, he had a story about a young boy named, or that was referred to as Fidgety Phil. And so this described a young boy who was sitting at the dinner table with his father and had a lot of trouble sitting still, a lot of trouble minding his father's directions. He was rocking back and forth and giggling so much that he, knocks over the chair, ruins the dinner. So a very hyperactive young man. And then he also described another young man that was referred to as Johnny Look in the Air. And this was a young boy who was described as always looking at the sky and the clouds that floated by. And he was so distracted as he was walking along that he ran into a dog and then fell into a river. So these are both regarded as, again, maybe early characterizations of kids that maybe suffered from ADHD. Though you could certainly make an argument that for Fidgety Phil, perhaps we were thinking more of like a ODD patient, someone who just has a lot of trouble with listening to instructions and authority. And then for Johnny Look in the Air, perhaps maybe even something like absence seizures, were being described. Moving forward a little bit from there into the early 1900s, we've got Sir George Frederick Still. That name might be familiar to you all, especially anyone that rotated through, or anyone that has experience in pediatrics, because he was the one that characterized what we now refer to as Still's disease. He gave a series of lectures. He was a British pediatrician and gave a series of lectures called the Gulstonian lectures, in which he described what he referred to as a defect of moral control as a morbid manifestation without general impairment of intellect and without physical disease. And so, again, a very long sort of name for what basically would be an issue with attention that is not due to an intellectual disability or some kind of physical organic cause. And he described a condition that was more common in boys, began in early childhood, and was characterized by inattention and impulsive symptoms. And then he also included within this symptoms that were characteristic of what we today would consider things like ODD, conduct disorder, learning disabilities, and even antisocial personality disorder. So again, what he described probably wasn't exactly ADHD, but it certainly captured a lot of what we think of as characterizing ADHD today. And then moving forward a little bit further into 1932, you've got a couple of German physicians, Franz Kramer and Hans Pollnow. They described the hyperkinetic disease of infancy, which the most characteristic symptom, as you might imagine, based on the name, was a marked motor restlessness. They also described children, that had various symptoms of distractibility, inattentiveness, and impulsivity. Interestingly, many of the cases they described, the onset of symptoms would follow some kind of febrile disease or an epileptic convulsion, suggesting that there was maybe some kind of organic cause of the symptoms. And that's important because in the early 1900s, what we saw was that hyperactivity eventually became associated with some sort of underlying brain damage. So if you had a child that was hyperactive, had trouble sitting still, fidgeted too much, anything of that nature, then the assumption was that there must be some kind of underlying, insult to the brain. Most of the symptoms at the time that described this minimal brain damage were consistent with, DSM criteria of ADHD today. But there were people that pushed back against this, argued strongly that there are certainly children that have a similar clinical picture, but have no evidence whatsoever of any kind of brain injury or sort of organic cause of their symptoms. And so in 1963, the Oxford International Study Group of Child Neurology, they advocated for a shift in terminology away from minimal brain damage to minimal brain dysfunction. Their definition of minimal brain dysfunction was also the first to really identify three main symptom clusters of inattention, hyperactivity, and impulsivity. So moving ahead a bit more, we get to something we're a bit more familiar with now is the DSM. So in 1968, DSM-2 was released, and it had a disorder that was called the hyperkinetic reaction of childhood, and it was described in the following two sentences. So it said, the disorder is characterized by overactivity, restlessness, distractibility, and short attention span, especially in young children, and the behavior usually diminishes by adolescence. So, a nice short summary of some symptoms and presentation that we usually associate with ADHD today. DSM-3 came out in 1980 and interestingly shifted the focus away from hyperactivity more towards the inattentive symptoms. That was because at the time, the inattention symptoms were thought to be more prominent, and they were the symptoms that seemed to respond the best to treatment, so to stimulant medications. And they renamed the disorder to attention deficit disorder with or without hyperactivity. And there were, a few, there was the, attention and then hyperactivity and impulsivity scales, and you had to have a certain number of symptoms from each. They each had a cutoff in order to get the diagnosis. The revision of the DSM-3 that was released in 1987 dropped the concept of the two subtypes and then renamed the disorder attention deficit hyperactivity disorder, ADHD. And those three symptom clusters, the inattention, the impulsivity, and the hyperactivity, were actually combined into one list of symptoms with a single cutoff score. And again, I don't have it up here on the flow chart here, but in 1994, the DSM-4 came and reintroduced the idea of subtypes. And so it reintroduced the subtypes that we think of today as, predominantly inattentive, predominantly hyperactive, or combined type. It was also the first that really accredited the diagnosis of ADHD in adulthood because it included examples of workplace difficulties in the depiction of symptoms. So it was really the, early and mid 1990s when adult ADHD or symptoms of ADHD in adulthood, they had been recognized prior to that, but where they were really given some credence, right? This idea that ADHD could be something that affected adults. And that brings us up to where we are currently in 2013, the DSM-5. I neglected to mention with the DSM-3 back in 1980, they introduced this maximum age of onset of symptoms of 7 years. So this idea that, the inattention or the hyperactivity should be present by age 7. From what I understand, there wasn't really any science necessarily to back that up, any data. It was more based on tradition, expert opinion. You can see how classically, even back in the 1700s, this idea was that symptoms started very young and then they would diminish as someone is as they age. And so DSM-3 introduced that maximum age of onset. DSM-5 in 2013 raised it 12 years. And that was based on some work that had been done that suggests that you could raise that maximum age of onset, and doing so would reduce the number of false negatives, when you're making a diagnosis. So, people who actually had the disorder would not be diagnosed as not having it, without increasing the number of false positives too dramatically. So they settled on age 12 for that. Also of note in DSM-5, they introduced this idea that to diagnose an ADHD in an adult patient, you actually had to only have 5 of the symptoms in any given category as opposed to 6, like we see in children. So that's, again, not an exhaustive history, but kind of brings us up to the modern day. And I want to shift gears here now and talk a little bit about the prevalence of disease. So this is one of the questions that I asked you all earlier. In children, the prevalence is thought to be somewhere between 4 and 7% of the population have ADHD. And then in adults, the estimated prevalence is around 2.5%. So I'm not sure what you all, when that question was on the screen, what you all would have guessed in terms of a number. I probably would have guessed, higher than 2.5%. I think that's probably biased by the fact that, I'm in an outpatient psychiatry clinic every day, and I see a lot of patients with ADHD. But so the idea here is that, it's a disease, it's more prevalent in children than in adults. The question, though, is, are all these adults who are experiencing ADHD symptoms or meet criteria for the diagnosis, did they represent the same group as the children, just, that maybe perhaps some of the children aged out of the symptoms, right? Classically, that's been what's understood. And so, if you think about the trajectory of the disease, it would look something like this, classically, that you have a certain number of children with the diagnosis, and then as they move into adulthood, some of the children's symptoms, they improve, they no longer meet criteria, and then you have a smaller subset of adults that continue to meet criteria. However, what I'm going to present is some data, some studies that have been done that suggest that the picture might actually look a bit more like this. right? That you have children with the disease, and some of those children continue with symptoms into adulthood and continue to meet the diagnosis. But the studies that have been done suggest that there are a number of adults out there who would meet criteria for the disease but did not have symptoms in childhood. So let's talk a bit more about that. So what I'm going to present to you now are a few longitudinal cohort studies that have looked at this. And I apologize for some of the slides here will get a bit text heavy. I'll try my best to highlight the key points, and I'm happy to make the slides available for anyone who would like to look at them in more detail. But again, we've got a few different cohort studies here. One from 2015 that was done in New Zealand. It was a birth cohort. So these, just over 1,000 individuals were followed from birth to age 38. And they were assessed at numerous time points. I don't have them listed here, but it was like, they were assessed at birth, then like age 3, 5, 7, and so on until age 38. In that cohort, the prevalence of ADHD was 6% in childhood and 3% in adulthood. So pretty close to those estimates that I mentioned earlier. Interestingly, the persistence rate of ADHD was only 5%, meaning only 5% of those who had been diagnosed with childhood ADHD continued to meet the diagnosis in adulthood. And around 90% of the adult ADHD cases then lacked any childhood history of ADHD. So that's pretty dramatic, right? A persistence rate of 5% is very, very low. There was a 2016 cohort. This one, I believe, was in Britain that found it looked at just over 2,000 individuals, and they were assessed at the ages listed here. And it found that 67.5% of patients at age 18 who had ADHD didn't meet the criteria at several points in childhood. The prevalence of ADHD estimated in this study was, they were a bit higher than what we described earlier. And again, the persistent rate was also a bit higher, somewhere around 22% of patients with persistent ADHD. And then finally, another 2016 longitudinal cohort. This one, I believe, was from Brazil, also looked at this issue. And this one included over 5,000 individuals. They were assessed for ADHD at ages 11, and then again at either 18 or 19. In this case, the prevalence of ADHD was around 8.9% in childhood and actually higher at 12.2% in adulthood. And they looked at this and said, well, what happens, if you remove the folks with ADHD, but, other psychiatric comorbidities? And if you do that, then the prevalence drops down to about 6.3%. But anyhow, they found, again, that, 87.4% of the young adults with ADHD did not meet the disorder, the criteria for the disorder in childhood, and their persistence rate was somewhere around 17.2%. So what all these studies share is this idea that there are, a pretty large number of adult patients out there who will meet criteria for ADHD, will meet all the criteria in DSM-5 except for the age of onset maximum of 12 years. And so, the question then becomes, well, first of all, are these true ADHD diagnoses, right? Do these adults really have ADHD? And to answer that question, these studies considered a few things. One of the cohorts we mentioned, that it was the one in Britain, they sort of looked at the individuals with late onset ADHD and then those with persistent ADHD, and found that they demonstrated comparable symptoms and impairment, as well as similarly elevated rates of comorbid psychiatric disorders. So when you actually looked at the impact, right, the effects of their diagnosis, it was similar between those who were diagnosed in childhood and those who were diagnosed in adulthood. One of the other cohorts, the Brazilian cohort, separated patients into groups of childhood ADHD, adult ADHD, and then adult ADHD without comorbidities. All those groups had similar levels of impairment in adulthood in terms of things like traffic incidents, criminal behavior, suicide attempts, and so on. And then there was another study in 2016 that looked at 182 individuals who met all DSM criteria for ADHD, including the age of onset maximum, 12 years. Compared those against just 17 who met all criteria other than the age of onset, and then 117 individuals without ADHD. And in that study, both of the ADHD groups had poorer quality of life and more impaired social adjustment compared to patients without ADHD. And the two ADHD groups had similar patterns of psychiatric comorbidity and other impairments. Now, again, that one had a very small group of adult onset ADHD, only 17 patients, but the pattern or the trend is similar to what the other studies found. So the studies that I mentioned here, among others, would suggest that, these adults with the diagnosis of ADHD really do see impairment, similar to the children who had the diagnosis and carried it into adulthood. So again, the final question that becomes, well, what really is adult onset ADHD? And there's really three main possibilities here. Possibility one is that it's the same disorder as childhood ADHD, but for whatever reason, it either didn't really present until adulthood, or there was a delayed diagnosis. It could be masked by certain protective factors like environmental factors. If you have very supportive parents who help you stay on top of like your assignments in school, help you keep up with things, remain organized, or perhaps, individuals with a very high IQ could compensate for the ADHD symptoms and they wouldn't be recognized until adulthood. Also, you consider here, it's pretty well known, right, that there are female patients, right, who are more of an inattentive presentation in childhood and don't always get noticed by their teachers or by physicians, and maybe, perhaps they would later get diagnosed in adulthood when they enter the workforce, things of that nature. So that's possibility one, is it's really just the same disorder. There's just a delay in diagnosis. Possibility two would be that, these adults that are being diagnosed with ADHD actually have some other non-ADHD, psychiatric illness. One of the cohorts, the British one that I mentioned earlier, they considered this question. And so in order to try to answer it, they eliminated adult onset ADHD cases that had comorbid anxiety, depression, cannabis dependence, and alcohol dependence. That left 1/3 of the late onset group that they found. And when they compared that group back to others with ADHD, they had similar rates of impairment and co-informant rate of ADHD symptoms. So those individuals, the symptoms they were experiencing didn't seem to be, due to depression, anxiety, any kind of substance use disorder, or so on. Now, that's just for disorders, right? There's certainly other psychiatric disorders like OCD, social anxiety, PTSD even, that could mimic ADHD. Or, someone could have subthreshold, symptoms, right, of something like depression or PTSD, not meet full criteria, but it could mimic ADHD, leading to a diagnosis. So certainly, that's a consideration. And then the final possibility, and one that, I think is a bit more controversial, is that ADHD in adult onset, represents a distinct disorder from childhood onset ADHD. And I've included some evidence here to support this. Again, in the British cohort, the adult ADHD group actually had a similar sex distribution. So there was a greater proportion of women in the adults compared to in the children with ADHD. And they also showed lower heritability compared to childhood onset ADHD. And that's something that's been replicated in other studies as well, that people with adult ADHD, it tends to be less heritable compared to childhood onset. Also, the individuals with late onset ADHD had fewer externalizing problems and higher IQ in childhood compared to those with childhood onset ADHD. In the New Zealand cohort that I mentioned before, the adult ADHD group actually lacked the neuropsychological deficits that we typically think of in childhood ADHD. So, we think of ADHD generally as a neurodevelopmental disorder, right? We expect some kind of neuropsychological deficit that could be demonstrated. The adult group in at least one of the studies did not have those deficits, but they still had similar rates of subjective cognitive complaints compared to the childhood group. And then the other consideration is that are there sort of phenotypic differences between adult ADHD and childhood ADHD? And so there's been a lot of research and there's a lot of literature on this idea that emotional dysregulation is a really prominent cluster of symptoms in adults with ADHD. One study found that there was a higher prevalence of emotional dysregulation in adults compared to children, something 30-70% adults, 24 to 45% in children. So, is this a separate diagnostic entity that presents with separate symptoms than we see in childhood? Certainly a possibility. In answering this question, or trying to answer this question, I think the best I can say is that the jury is still out. There's certainly evidence that argues for each of these possibilities and evidence against. I think as we think about number three, this idea that it's a distinct disorder, I think one of the large missing pieces would be, well, so what's the pathophysiology or the etiology of adult onset ADHD if it's different than childhood onset? And I don't think that question has a great answer right now, at least from what I could find in the literature, but it's something that, will continue to be investigated. Speaking of pathophysiology, I don't want to spend too long on this, but I think it's at least worth mentioning as we talk about the disorder. So we'll break it down into structural imaging, functional MRI, and then neurotransmitters. Structural imaging studies in ADHD have found changes in brain volume in various regions. As you might guess, the prefrontal cortex, but then also the cerebellum, the corpus callosum, and caudate. And then diffuser tensor imaging, which actually looks at the white matter tracks between these areas of the brain, also show alterations in structural connectivity. So it's not just the brain regions themselves, it's connections between them that seem to be altered in patients with ADHD. Functional MRI, so this is typically comparing someone's brain at rest compared to when they're doing some kind of attention task. And these studies have shown a hypoactivity of several brain regions, again, including the frontal regions, the basal ganglia, thalamus, parietal cortices. But they've also shown that there are regions of the brain that actually are more active in folks with ADHD, particularly the insular cortex, middle frontal gyrus, left thalamus, right paracentral lobule. So the question is, why are certain areas of the brain, more active in folks with ADHD when they're trying to do some kind of, attention task versus others? So there's this kind of debate between, does this represent compensation? Like, are those hyperactive areas of the brain more active because it's compensating for the areas of hypoactivity elsewhere? Or does it represent intrusion of areas of the brain that really shouldn't be active but are? On that end of the debate, there's this hypothesis, the default mode interference hypothesis. So there's a network of regions in the brain called the default mode network that we typically think of as being active when someone is more at rest, right? Not doing some kind of task that requires direct attention. And the idea here is that in patients with ADHD, perhaps that area of the brain is overactive during an attention, some task that requires attention, thus causing interference and leading to the problems we see with attention in patients with ADHD. And then finally, neurotransmitters. So this is probably the pathophysiologic mechanism that most of us are familiar with. This idea that because stimulant medications increase, dopamine and norepinephrine activity, it means that ADHD must be caused by hypoactivity. Similar to the way we think about like the monoamine theory in depression, right, with SSRIs. So there is evidence to suggest that there's hypoactivity of dopamine and norepinephrine in these patients, but there's also evidence to suggest the opposite, right, that hyperactivity of dopamine and norepinephrine can cause attention problems. And so, how do you reconcile this? Is it not enough activity? Is it too much activity? There's really two ways that have been proposed, and so we'll review these. The first is of a U-shaped dose response curve, and so I took this figure from one of the studies that I reviewed in preparing this lecture. And so if you look here, going from I guess what's your all's left to right. On the left, you see the fatigued state, and then in the middle, the alert state, and then red is the stress state there on the far right. And in the fatigue state, the idea is that there's too little dopamine and norepinephrine activity, which leads to unguided attention responses, people being distracted, and so on. In the far right, you've got the stress state where there's excessive dopamine and norepinephrine activity, And so here, again, you've got misguided attention, mental inflexibility, and so on. In the middle, you've got moderate levels of dopamine and norepinephrine activity, which is associated with the alert state. This is when folks have guided attention, they're focused, they're organized, they have a good mental flexibility. So it's kind of like a Goldilocks principle, right? It's not too little, not too much. You've got to find the levels of dopamine and norepinephrine that are just right to facilitate attention. And then there's also this theory of there being two different pools of dopamine and norepinephrine that are active in the brain. And so this figure includes a depiction of a dopaminergic synapse. So on the left here, you've got the presynaptic terminal. You can see the vesicles that have the dopamine or the yellow circles stored. You can see the dopamine transporter down here at the bottom. And then at the top, there's these, dopamine D2 and D3, like autoreceptors. And on the right, you've got the postsynaptic terminal, you've got postsynaptic D1 through D5 receptors. And the idea is that there is, a certain tonic level of dopamine that's active at rest, and that feeds back on those presynaptic dopamine receptors, so that when there is some kind of, impulse or stimulus, it modulates how much dopamine is released, right? It makes sure that the right amount of dopamine is released, that then leads to attention, focus, organized thoughts, and so on. The thought is that perhaps in folks with ADHD, that tonic pool of dopamine is lower than it should be, right? So you're not getting that same level of feedback. And so when there is some kind of stimulus, they're not able to modulate that in the same way, or moderate that in the same way, leads to too much phasic dopamine release, which then causes problems with attention. The idea is, right, the stimulant medications, what they really do is they increase that tonic pool of dopamine to an appropriate level, which is then going to have the right amount of feedback and regulate that response correctly. And then I don't have it pictured here, but the same idea applies to noradrenergic neurons as well, that there's this idea of these two pools. We spent some time talking about this, and the question is, well, so what, right? So if there are adults with ADHD, does that really, how big of a deal is that, right? Why should we care? Like any other, illness that we treat, the idea is that we're trying to, limit the morbidity, the issues that come along with it. So when we think about the burden of adult ADHD, we break that down into personal costs. So things like poor self-esteem, reduced quality of relationships. Adults with ADHD have been shown to be more likely to get divorced, to be arrested, to be unemployed. And the individual loss of income for an adult with ADHD is estimated between $8,900 and $15,000 annually, right? So I don't know about you all, but if I had, some disorder that, could be treated, that was causing me to lose, $15,000 a year, I'd want to do something about that. So from a personal standpoint, it has some costs. And then also, from a societal view, I mentioned before that adults with ADHD are more likely to have been arrested. So I think it's in society's interest, to try to reduce crime and whatnot. So that's one component, but then also the financial component from a societal level. ADHD associated loss of workforce productivity is somewhere between 67 billion and 116 billion annually in the US. So quite a bit of money. And then just the overall cost of ADHD in the US is somewhere between 143 and 266 billion. So again, a large part of that coming from loss of productivity. But, this is an issue, right? And so we should, as psychiatrists, we should probably be doing what we can to address this. But that's the hard part, right? Is, well, what do we do about it? How do we correctly identify these individuals with ADHD and treat them appropriately? This is especially important because it's not a secret that, an ADHD diagnosis is in high demand, right? We have individuals, especially we think of individuals, at the college level, that are taking classes and whatnot, that have a reason to seek an ADHD diagnosis, to receive stimulant medication for reasons outside of just treating ADHD symptoms, right? This idea of cognitive enhancement or using it as a recreational drug and so on. So it's then on us, right, to think about, well, how are we going to correctly identify these folks and treat the people that need treatment without just overprescribing stimulants to, every person that walks into our office. So in thinking about diagnosing adult ADHD, I think with any psychiatric illness, a good place to start is the DSM criteria. So I'm not going to read through these word for word, but I just wanted to include them here as a quick review. So generally, we think about, the symptoms being persistent. They have to interfere with functioning. For ADHD, they need to have 5 or more of the inattention symptoms, which, I won't go through all the details of those, or 5 or more of the hyperactivity and impulsivity symptoms. I underlined the 5 or more there because remember, that's different than childhood ADHD. It would be 6 in that case. It's 1 less for adults. And then the other criteria here, as we mentioned, the age of onset maximum of 12 years is present in DSM-5. The symptoms need to be present in multiple settings. So, for example, at home and at work, or, at home and at school. There's evidence that symptoms interfere with functioning, basically, and that the symptoms do not occur during the course of some kind of psychotic illness or other mental illness. And as I mentioned before, there's a number of specifiers. The ones we most commonly think of are whether someone has the combined presentation where they meet criteria for both the inattentive subtype and the hyperactive and impulsive subtype, or they could meet criteria for each of those individually. You can specify for individuals whether they might be in partial remission. So these would be folks who met full criteria at some point, but for the past 6 months, they don't meet full criteria, but still have some level of impairment from their symptoms. The literature is full of data to support this idea that even the children who no longer meet criteria for ADHD once they become adults, they're still impacted by the symptoms and they still report impairment. They just don't necessarily meet the full criteria. So this is a case, or that's a case where this specifier might apply. And then of course you can specify the severity, mild, moderate, or severe, depending on the number of symptoms and the severity of the disease. So how do we operationalize, the DSM criteria and actually make a diagnosis in a clinic setting? Well, one of the ways that we do that is through the use of psychopathological rating scales. And really these could be broken down into two categories, right? You have scales that are looking at the current symptoms, the current psychopathology, and then scales that focus on a retrospective assessment of childhood symptoms to try to go back and make the diagnosis historically. So I want to give a couple of examples of validated instruments that would be options to use in a clinic setting. So one is the Winder Utah rating scale. The original had 61 questions, which isn't the most I guess the best if you're working in a busy clinic environment, where you have to move quickly with patients sometimes. So they actually did also put out a shortened version that has only 25 questions, and they selected those 25 questions during the validation process by picking the questions that showed the greatest mean difference between ADHD and non-ADHD patients. So these questions basically give you the most bang for your buck. I've put some psychometric properties of these tests here. I'm not going to read through all these. That information is there if you're interested in looking at it. But I did want to show what this actually looks like. So this is the worst 25 that I mentioned. And so again, a pretty brief screener. They think about back to childhood. They'll say whether or not they had these symptoms, and they can rank them from not at all or very slightly all the way up to very much. And so I didn't mention it, but the cutoff score that's recommended is 46. So that's what you're looking for. And anything above 46 would be suggestive of a potential ADHD diagnosis. This is one that those who work over in the outpatient clinic might be familiar with, the Adult Self-Report Scale, or ASRS. This is actually the official instrument of the World Health Organization, and it's 18 questions, so easy to use in like a clinic setting. It's divided, the most recent version is divided into two parts. You've got part A, which is just 6 questions that have been shown to be the best used for screening, and then part B, which has an additional 12 questions that again aren't used as part of the screening instrument, but can help characterize the symptoms the person might be experiencing. And so here's a picture, and I apologize that the top's being blocked off there, but again, you have part A at the top and part B at the bottom. The shaded boxes basically just indicate the answers that would be considered significant. So I believe it's in part A, if someone has 5 of the 6 in the shaded boxes, they would meet criteria for a positive screen. And then in part B, again, you're not using that as a screen, they're just to help characterize the symptoms. And then I also wanted to include the Connors Adult ADHD Rating Scale, or CARS. I mentioned earlier that I did some training in an ADHD specialty clinic in residency, and this was the screening instrument that we used there. I guess the downside of this one will be that it's not free, so you can't just go on the internet and find a CARS to give to your patients. So there is a fee associated with it. But what I liked about this scale when we used it in that clinic was that it has both a self-report and an observer report, so you get some more information from perhaps a spouse or a parent. And again, it was hard for me to find many pictures to show you, but I did find this picture of one of the reports that you'll get after someone completes the CARS. And so I want to kind of walk through this briefly. So on the y-axis or the vertical axis, you have T-scores from 25 up to, I believe, 90. And on the horizontal axis, you can see that there's a variety of categories here labeled A through H. A is inattentive and memory problems. B is hyperactivity or restlessness. C is impulsivity, emotional ability. D is problems with self-concept. And then E is just kind of captures the DSM-4 inattentive symptoms. F is the hyperactive impulsive symptoms from DSM-4. G is like the total ADHD symptoms. And then H is this ADHD index sort of summative like combination score that that they came up with. And you compare the patient to age matched norms. And so it might be a little bit hard to see, but you can see like there's an F1, F2, F3, F4, and so on. Those are different age ranges, right? So you want to make sure you're comparing the patient against their appropriate age range. And what you get is this nice visual representation. So anything above a T-score of 65 is considered abnormal compared to, age matched norms. And so it's a good visual representation of someone's symptoms, and you can kind of get a quick look at the severity. And then you can also plot, like the self-report against the observer to see if they align. So again, I really liked using this one in training. I feel like it gave a lot of information and did so in a visual way that was a bit easier to read and decipher. But again, unfortunately not free, so you would have to pay a fee to be able to use it. As we mentioned earlier, when we think about the diagnosis, like most psychiatric illnesses in the DSM, there has to be some effect on someone's functioning, right? It has to cause some level of impairment. There is a tool that's used to help quantify this. It's called the Adult ADHD Quality of Life 29, or the AAQOL 29. Here's the AAQOL 29 here, and again, just a variety of questions. The patient thinks back over the past 2 weeks, and they answer how often they've experienced these problems. And so again, you can use this as a way to sort of quantify, how severe are these symptoms, what kind of impact is it really having on the patient. So neuropsychological testing is something that gets ordered a lot for ADHD, especially in adult patients when we're trying to feel more comfortable with the diagnosis. I've trained with individuals who would say that they won't treat anyone, that's an adult that doesn't have neuropsychological testing. I've trained with individuals who sort of say, oh, you don't need it, it's a clinical diagnosis. What good does it do really? The data supporting the use of neuropsychological testing in ADHD really is mixed on how effective it really is. There was a 2019 study in which individuals with and without ADHD went through neuropsychological testing batteries, and in that study, the individual neuropsychological tests really did a poor job of discriminating between the ADHD and non-ADHD patients. The measures that were the most effective were things like working memory, inhibition, response speed and variability, and sustained attention. But even those, again, didn't do a great job. Dr. Casey.
The idea of having false positive and false negative, you don't have a gold standard test. Or you do the gold standard test, and it differs from what your predetermined guess about the diagnosis was. It's really
Yeah, I agree that you've got to consider that, right? I think they were comparing to, if I remember correctly in this study, I think they were comparing to, clinician diagnoses with either a structured interview based on DSM-5, or I want to say that it was a structured interview based on DSM-5 with like a psychologist or a psychiatrist. So again, right. So you've got to consider that. I think that's fair. That same study did find an 87% classification accuracy when you combined a few things. One, self and informant ADHD symptom ratings, so like similar to the CARS that we mentioned earlier. Two, the presence of a family history of ADHD. And then finally, the TOVA measure of response time variability. And the TOVA, or test of variables of attention, is a continuous performance task, which we'll talk a little bit more in detail about here in a moment. But that study did suggest that when you combine these three things, the 87% classification accuracy is reasonable. It's also important to consider that, and we mentioned this a little earlier as well, that people with a high IQ, high baseline IQ might underperform relative to others in their own IQ group, but still fall within the average range if you compare them to the broader population. So they could have ADHD, and maybe it looks like they don't because their scores seem, they're still within the average range. But then based on their, their intellectual capabilities, they should be in, the high average to, superior range. So it's really important that, that the results are compared to an appropriate reference group. And also that testing should include some kind of performance and symptom validity measures. As I mentioned before, there are people that will go into neuropsychological testing and they'll try to help the test, right? They want it, they're maybe experiencing symptoms and they really want the diagnosis to help with the symptoms. So they're going to try to help the test, or they don't have symptoms and they're trying to get a diagnosis, to use a stimulant recreationally or whatever. And so some sort of measures to sort of pick up on that, is important when you're giving neuropsychological testing. There have also been studies that have looked at neuropsychological testing's ability to differentiate individuals who have ADHD, not just from, people without ADHD generally, but from individuals with other psychiatric illnesses. So the idea here is that lots of psychiatric illnesses could lead to some level of, dysfunction or impairment on neuropsychological testing. And so how do we know we're really picking out ADHD versus, we're picking up on depression or something? And again, there have been studies that have looked at this and suggested that, neuropsych testing doesn't do the greatest job of this, even when you account for treatment in the ADHD group. Because the thought might be, well, ADHD patients who are treated are going to seem, more like, maybe some normal patients, right? Quote unquote normal patients. And even when you remove those, it still doesn't do a great job of distinguishing between the groups. The measures that have been the most promising in these cases have been the continuous performance tests. So I mentioned the TOVA earlier, but there's also the Connors Continuous Performance Task 2 and something called the QB test, which is also something I've had some experience with at the Student Health Clinic at the University of Kentucky. They used the QB test, and a continuous performance task generally is like a computerized test where, the patient will sit in front of the computer and they'll basically be presented with some kind of mundane task that they're going to do for an extended period of time. Some of them are like 14 minutes. I think there are others that are 20 plus. For example, it might be that, letters will flash on the screen and they're supposed to hit the space bar every time they see the letter X. And the rate at which the letters move or how often you see an X is going to vary throughout the test. And then the test is going to be recording, well, how long did it take them to respond? Like, what was their variability in response time? How many correct answers did they give? So, or how many did they miss, omissions, commissions, and so on? And it's going to combine all that data to spit out some statistical measure and tell you how likely it is they might have ADHD. So those have actually shown some promise for differentiating these patient groups. Specifically, the inattention item on the QB test, which considers omission errors and reaction time variability, has shown high specificity in differentiating the two groups. The other interesting thing about the QB test is that it also has this kind of head tracking, a motion tracking component where they wear something on their head that a camera follows, and it's supposed to help be a measure of the hyperactivity, restlessness, fidgeting, things of that nature. So it combines that as well. And then I wanted to include some recommendations from the Canadian ADHD Resource Alliance, or CADRA. They have an ADHD practice guideline, actually, that is it's a pretty interesting document and something that I'd recommend taking a look at just in terms of how they recommend going about evaluating and treating ADHD. But they make some comments on the role of neuropsych testing that I wanted to point out. So they say that testing is generally most useful in those situations of diagnostic uncertainty, right? So if you have a patient where the history just seems a bit off, or they have several comorbid psychiatric disorders, they recommend using it in that case. That the testing should be interpreted in the context of the broader clinical evaluation, given issues as we mentioned with like sensitivity and specificity of neuropsychological testing. They point out that not all individuals with ADHD are going to show impairment on the standard neuropsychological testing alone, and that testing should not be used to determine the severity of ADHD or quantify its impact on cognitive or academic functioning. And the argument they give is that it doesn't really measure the real world impairments that patients with ADHD have. So as you can see, not the most ringing endorsement. They don't say to completely ignore it, but I think that they would argue that it's not the gold standard, sort of end-all be-all for making a diagnosis of ADHD. Another thing that often comes up is, the effect of cannabis use in terms of attention and how it might affect neuropsychological testing. So I just wanted to put a brief, do one slide on this. So it's been well characterized that or cannabis use has been understood to lead to cognitive deficits in areas of executive functioning, memory, and attention. I included this line because it says acute intoxication is associated with increased impulsivity, impairments in episodic memory, working memory, verbal memory, and attention. That sounds a lot like someone struggling with ADHD, right? So, someone acutely intoxicated with marijuana might be misdiagnosed. And then there was also a study that compared chronic tobacco and chronic cannabis users, and predictably, it showed that the chronic cannabis users had poor learning, poor delayed recall, increased forgetfulness, decreased reaction time during information processing and attention tasks. So this is just a small piece of the data. The data out there that suggests that cannabis can have these sorts of effects is pretty extensive. The question then becomes, if you're evaluating a patient for ADHD, that they're a cannabis user, how long do you wait? If you tell them, I want you to abstain from cannabis use. If you were going to refer them for neuropsych testing, for example, how long would you wait? Like, how long would they need to be abstinent for those effects no longer to be present? There was a 2012 study that looked at this, and it was a study that actually did two separate meta-analyses. So it did one meta-analysis of 33 studies that looked at active cannabis users. And it found a small but significant effect both globally on neuropsych results and then on 6 of 8 individual neurocognitive domains that I listed here. So small but clinically significant effect of cannabis on the testing results. And then they also did a meta-analysis of 13 studies that looked at cannabis users who had maintained or had been abstinent for at least 25 days before testing. And in that group, they actually found no evidence of lasting effects on cognitive performance due to the cannabis use. So their answer to that question then would be, if you're going to tell someone to abstain from cannabis and then reassess for ADHD, you should probably wait at least a month, if not a little bit longer to be safe. In my practice, I have told people generally, if you can be absent from cannabis for about 2 to 3 months, we can reassess and see how you do, especially if there's not that, again, kind of class history of symptoms beginning early in childhood. Just a quick note here, and I want to leave a little time for questions, so I'll go quickly, but you want to make sure you assess for any comorbid diagnoses. ADHD comes with a lot of comorbid psychiatric disorders. The most common ones would be things like depression, anxiety disorders, bipolar, substance use disorders, and personality disorders. It's important to keep in mind, though, that untreated ADHD itself can lead to increased stress, which can make people feel depressed, make them feel more anxious. So it's really important when you're taking the history to try as well as you can to tease that out. Did the depressive and anxious symptoms precede the concentration difficulties? Do they feel more depressed and anxious because they are so, unproductive or disorganized? So you need to try to tease that out as much as you can. Also important is, I mentioned earlier that adult ADHD, the literature suggests that emotional dysregulation is a pretty common feature, and that it can often be misdiagnosed as something like, a bipolar disorder, depression, or so on. So keeping those things in mind is important. I included this graphic, and I won't go over it in detail, but it's basically just a way to show that you have ADHD in the middle, all symptoms of ADHD on the outside, and then the squares, you've got depression, anxiety, and so on, showing where the symptoms overlap. And so you can see, it'd be easy to think someone who is maybe fidgeting, worrying, irritable, it might be easy to lump them into generalized anxiety disorder and forget, to really screen or assess for ADHD. So keeping that in mind, that it's really important to try to tease that out. And of course, how you do that can vary. Some people really like to use screening instruments, and they'll rely on things like the GAD-7 or PHQ-9. I'm not a huge fan of that personally, or in my practice at least. I usually just will do it more through clinical interview and try to kind of get a timeline down of symptoms, but they're obviously different approaches. So let's spend the last bit here talking about treatment. We'll break this down into a few categories, starting with pharmacotherapy. And so generally, I think it's pretty well or I would assume that most people would think that stimulants are the gold standard treatment. And there was a 2018 systematic review and meta-analysis that kind of looked at the various treatments for ADHD in both adults and children and tried to make recommendations about what's best. That study suggested that really amphetamines for adults gave the best combination of efficacy and tolerability. There's some details here. Again, if you want the slides, I'm happy to provide them so you can look through that. But the takeaway was that they recommended amphetamines. There's also been studies that have looked at how effective are our ADHD medications for treating the emotional dysregulation we see in adults with ADHD. And the short answer is that there's some evidence that suggests they can help. And on that note, when we think about emotional dysregulation, treating ADHD with comorbid bipolar disorder can sometimes be difficult, because there's a concern that treating these individuals with stimulants is going to lead to excessive dopamine activity, lead to mania, psychosis, and so on. There is evidence and case reports and whatnot suggest that if you manage the bipolar disorder first with a mood stabilizing agent, that you can safely and effectively treat the ADHD as well with stimulants. But it's obviously something you have to monitor closely. Also of note, when treating patients with comorbid ADHD and anxiety disorders, that's a situation where, again, stimulants might exacerbate the symptoms. So you could consider Strattera. It has evidence for helping with both ADHD and anxiety, or perhaps even a tricyclic antidepressant. Other treatments that have some evidence in adults I didn't include here were things like SNRIs, for example, have some evidence, and as well as alpha agonists. I think we're probably all familiar with clonidine, guanfacine, and so on. The evidence there is not as robust in adults as it is in children, but there is still some evidence regarding their efficacy for ADHD in adults. Going back to those CADRA guidelines, I just included this table here to show what they recommended in terms of treatment. It's pretty small, so I'll just quickly go through some things here. For first-line agents, they have the long-acting psychostimulants, including Adderall XR. They recommend long-acting because the risk for abuse of long-acting stimulants is thought to be less than short-acting or intermediate-acting stimulants. So their first line is the long-acting. Their second line is short-acting or intermediate-release stimulants. And then they also have on the second line the long-acting non-psychostimulants such as Strattera. There's probably some in the clinic that have started using Qelbree as well. It's another norepinephrine reuptake inhibitor like Strattera that has some evidence. So again, checking out the CADRA guidelines, not to say that they're, infallible by any means, but it is interesting to look at what they recommend. A short note here that, again, people often want stimulants to use as cognitive enhancers. The data suggests that, again, it's a little mixed. How much do they really help individuals without ADHD from a cognitive standpoint? Summarizing the literature here, I would say that most of the studies I saw suggest that individuals with like a baseline low IQ do see some cognitive, enhancement from using stimulants, even if they don't meet criteria for ADHD. Whereas individuals with a high baseline cognitive ability might actually see some impairment. And so it kind of goes back to that idea we talked about, maybe of the U-shaped, dose response curve, and that sometimes too much, dopamine activity is a bad thing, and it's about finding that just right level. I included this psychosocial interventions just because if you're like me, you'll sometimes get patients asking for, letters for accommodations for ADHD, and maybe in the workplace, and you're like, well, I don't really know what accommodations to recommend or what kind of things might help. These are also from the CADRA guidelines. So, things like, these are more things just used generally, like visual reminders, labeled, bins to store things, working in quiet spaces. Specifically in college, if there's an accessibility or disability center on campus, getting your patients to get plugged in with them is a good idea. Recommending things like extended time for exams, preferential seating, maybe someone to help take notes. All those things can be helpful. Workplace interventions, so recommending regular and frequent meetings with their manager for feedback and direction. There are certain productivity apps and websites out there that can help. There are individuals in the community that work as ADHD coaches that ADHD patients can hire, and they'll kind of help them with some of these strategies. So that's something else that you could consider. And then a couple last things here. There's evidence behind cognitive behavioral therapy being helpful in ADHD compared to things like wait list controls or even inactive controls. And then a 2019 Chinese study looked at CBT plus medication versus CBT alone, and The results were similar to what we think about with depression, anxiety, and that, probably the combination gives the best results, but either can be helpful. Dr. Casey?
I think one of the limits of that strategy is most therapists not trained on CBT4 ADHD.
Yes.
You send them to the therapist, they might not get treatment that they're supposed to get.
Yeah, that's fair. And so that's, I think that's one reason why some people use these ADHD coaches, that have more experience in that regard. There's also a book that I've purchased but haven't read, but that I kind of recommend to my patients based on just the people I trained with that, have recommended it to me. And I've had patients use it and get good results. I think it's called Adult ADHD Toolkit. It's a cognitive behavioral something in the subtitle. I can share it with anyone who might be interested. Like I said, I have a copy if you ever want to look at it. I need to look at it myself, but there are resources out there to help with these kinds of things, like self-help books or books to help guide, providers as well. And then my last slide here is I just want to make a note about mindfulness practice. So again, there's some evidence to suggest that these sorts of practices can be helpful compared again to like wait list controls. There was one meta-analysis in 2021 that found that again they were helpful compared to wait list controls, but not necessarily compared to active controls like psychoeducation or skills training groups. But mindfulness is something that can really just be helpful in general. So there's a little bit of evidence. So it's certainly something to think about with your ADHD patients. So just quickly in review, just a couple of the highlights here. ADHD is classically described as a neurodevelopmental disorder of childhood. Adult ADHD appears to be a valid diagnosis, though it remains unclear how it relates to the classic childhood illness. Again, whether it's delayed diagnosis versus separate diagnostic entities. Adult ADHD is generally best diagnosed with a combination of self and observer reports, family history and first degree relatives, and some kind of continuous performance task, like I listed earlier. And then treatment should include both, should include behavioral, psychosocial, and pharmacologic interventions, with psychostimulants and particularly amphetamines as the first line option for most adult patients. And some citations there. And yeah, any questions or thoughts? Dr. Ells.
Yeah, I just wanted to mention the book I use with adults with ADHD. I find it useful. I got a good response, not always. It's called Understand Your Brain, Get More Done, and it's by Ari Tuckney, and it's a pretty good book. It takes it views adult ADHD through the lens of impairment and executive functioning. It's got a nice brief part one, only like 30 pages, and then separate chapters that could be read in any order on specific areas of dysfunction. It is a lot of work, and he said that it's introductory part. I would say that with some patients, but he's got a plethora, let's say, of tips and exercises.
Awesome. Thank you. Dr. Casey?
Well, thank you for a wonderful presentation. Really appreciate it. And we're certainly very happy to figure on the faculty. So
thank you.
Very nice. There's so many questions that come to mind. I don't even know where to start. But I'll start with one that's very vexing for me. I'm the psychiatric consultant for the board, Board of Medical Licensure. And we've had a spate of cases that involve providing stimulants, sometimes in high doses, to people who previously been diagnosed with other psychiatric disorders other than ADD or ADHD, including bipolar disorder in particular, but others as well. And those people subsequently suffering psychotic episodes that may or may not be related to the stimulants that they take. So I'll give you another category. See if you can sort of link these together or address both. The other is in our geriatric practice, and some of the residents including see this in the clinic. We have a fair number of people who come to us in their 70s or 80s sometimes, who are taking stimulants, often large doses of stimulants that haven't taken them for decades, and they want to continue or sometimes even increase the dose. It's very difficult for us to disentangle the effects of aging or existing cognitive disorders and separate those from symptoms of ADD. And the kind of instruments that we normally use seem to be grossly inadequate.
Sure.
This person's been medicated for decades. I had a patient last week, someone who's approaching 80, whose internist told her that she shouldn't be taking stimulants. They were recommended for older patients. There's a world older patient taking stimulants. You see them all the time. Their reactions to those situations.
Yeah. So, I'm not aware of any instruments that have specifically been validated for ADHD diagnosis in like a geriatric population. But you're right. That's certainly a difficult population when you consider the impacts of just normal aging, or even things like major neurocognitive disorder on cognition and attention. I would say that, I guess when I'm treating patients, at least that are geriatric patients on stimulants, I'll really go back to just this idea of risk versus benefit, right? What are the scenarios in which they would really need to be highly focused, right? Are they still working? Are they caring for children? How often are they driving? Things of that nature. And if they do have those needs, then that's a situation where, would certainly have the conversation with them of the risks, right? Especially in that age group, as is the cardiovascular risks we think of as being particularly significant. And again, I would just come down to like a risk benefit for that specific patient. I don't have a better answer outside of that. The stimulant-induced psychosis is a difficult one. I can think of a patient in my practice who is a gentleman who I'm now treating for schizophrenia, but presented initially to the hospital as what was thought to be like a Adderall-induced mania or psychotic episode, because he had a history of ADHD and was overusing his prescribed stimulant. And kind of communicating that to him and helping him understand how that might have played in and what happened is difficult. Again, I think that's a case where, if you're going to treat individuals with those kinds of comorbidities, it's very important, to make sure that the comorbid illness is well controlled and stable before you would initiate treatment. And it's a situation where you might consider non-stimulant options, right? If a person is adamant that they need some kind of treatment for their attention issues, you might consider, Strattera, Qelbree, alpha agonists, things of that nature before going to stimulants, even though the data for their effectiveness isn't as great, just to limit that risk of, contributing to mania or psychosis. It's the best I have for you on that. Dr. Casey.
Comments on some recent articles about this topic. Number one, there's one by Perone, who reevaluates the New Zealand study and the Brazil study. And in his reanalysis, the same data, he finds that the vast majority of people who are borderline cases, people who were diagnosed in childhood who don't have it as adults, they have borderline cases in childhood, or people who were diagnosed as adults but not when they were children, they were borderline when they were children.
Sure.
And it's really about people who are both born within 1 or 2 points of meeting the disorder.
Sure.
And it does not support the idea, at least in his mind, of being a separate condition. Or at least that is not the evidence for it.
Right. Yeah.
Secondly, there's been a recent article about the ADHD potentially being a risk factor for dementia. It was an Israeli study. And in that study, they found that people who had adult onset ADHD, most of these patients were in the 50s, 60s, had a 3 times higher rate of developing dementia.
Sure.
And they were saying that it's clearly ADHD is a risk factor for dementia. I think you could read that just easily to say that is a concentration problem one of the first symptoms of many kinds of dementia.
Yeah. I think that's interesting. And I think the question there would be, for those individuals, right, who start with concentration issues, go on to develop dementia. I guess the question for me would be, well, so they have clinical symptoms that present as ADHD. Are the treatments that we classically use for ADHD helpful for those individuals, right? I feel like that would be an interesting question to answer. Or is again, are we looking at something completely separate, right? That it would need some kind of different treatment. I guess that question would obviously remain to be answered. What you mentioned about, Dr. Ferrone and the response or the reanalysis of the studies, I think I've read that as well. That same response that you mentioned, and if you notice, Dr. Ferrone was a name that came up, some in my citations. Yeah, I think that certainly, there's a question again of, how many false positives are we looking at when we think about the adult population? And the question to me then shifts more towards, well, are there like phenotypic differences, right, between these two groups, and do the disorders, while they do have similar, symptoms and maybe similar impairment, are there differences that would suggest that they are separate disorders? It's things like the higher rates of like emotional dysregulation that you could argue perhaps say they are, the less, they'll reduce less for heritability. But again, I think that what you're pointing out is kind of what I was hoping to allude to, is that the jury, I think, is still out some on this. I don't think there's a definite answer. It really depends on how you interpret the data. And for some folks, I think it depends on, sort of the biases we might have from, tradition and whatnot, is considering it purely as a neurodevelopmental disease, when perhaps there is, a subset of adults who have some disorder that's very similar that maybe doesn't have a neurodevelopmental origin. But I think the evidence to support that is lacking.
I have two questions for you.
Yeah.
If you have time to answer both of them. The first is the role of urine drug screening in either evaluation of ADHD or with the use of medicines. And second would be, what is the evidence for medication holidays? Should they be recommended?
Yeah. So on the first note, I'm not prepared to talk about literature around the utility of the urine drug screens. I'll say in my own practice, I tend to do them at least, I do them when I initiate treatment. And I do them, at regular intervals after, but not terribly frequently, maybe around once a year, just routinely, to check for compliance.
The Canadian treatment guideline that you had mentioned earlier, I reviewed it, it's over 100 pages.
Yeah, it's a long document. Yeah, I see. I think for me, it would be more about just identifying those folks who might already have a comorbid substance use disorder and trying to address that with them before introducing a substance that could, in some cases worsen that. Although I didn't mention this, but it's important to note that there is, a fair amount of data suggesting that treating ADHD actually reduces the risk for substance abuse. So you've got to keep that in mind. I wouldn't say a substance use disorder history is an absolute contraindication to treating, but I think it's something you need to weigh as you begin treatment with a stimulant medication. I have had a couple patients in my own practice that, in routine sort of screening that I'm doing because they're receiving ADHD medications, I have identified, that, oh, your screen is positive for heroin or whatever else. And that opens up a conversation of, well, what's going on there? What do we need to do about this? On the second part of your question, I'm not aware of data supporting drug holidays. It might be out there. I'm not aware of it. Theoretically, of course, the idea is that drug holidays would help reduce the potential for tolerance developing and thus the medication losing efficacy over time. In practice, like anecdotally, I have patients say it helps, but I'm not aware of the data on that. And then really quickly, just Dr. Wong had a question, what's the dose response curve for amphetamines? And I don't know the answer to that. I'm not entirely sure at what point you move from that, just right amount of dopamine activity to the amount that's too high. So, all right. Any other questions? We're right at 1 o'clock here. Thanks, everybody.